For EKG, this is the second module, and this module has parts 1 and 2 that we'll be talking about. And these, so you'll have a PowerPoint for part 1 and a PowerPoint presentation for part 2, all part of the second module. This second module material will go into be a part of exam 2. All of exam 2 will be taken out of this. So if we're kind of looking ahead to that exam, if you have your small text book and you're looking at that, that would be very helpful as I talk and we go over this PowerPoint presentation, starting on page 10 in the small text. And then if you have the course pack, and again, it would be good to be looking at that for this presentation, starting on page 8 in there. So I have my books open, and hopefully you do, and we'll go ahead and talk through this material. The topic is ischemia and injury. And then eventually we'll start to talk about infarct, and then later on hypertrophy. We'll begin with ischemia and injury. And as an introduction to this, then if you kind of look through the small text, pages 10, 11, and 12, 10, 11, at the top, the author is showing first of all, a coronary artery vessel, and he's showing that it's open on the far left, and then he's showing that it's blocked with atherosclerosis, which is the something that causes ischemia or lack of oxygen to the heart. And then he's showing injury, and then finally infarction. If you follow the EKG, the main thing we want to look at first is the ST segment. And if you look to the far left on page 10 in the text, the small text, you see that the ST segment has is right about at the baseline. We talked last time a little bit about the baseline and up and down like that. If you look at the ischemia area, it will show ST segment depression. That'll be a big part of what we are talking about initially today. And then as you go into the injury area, it goes to ST segment elevation. And you can see that again on the top of page 10 in the text. And then when somebody has an infarct, where you have tissue damage that is irreversible, there's damaged or dead tissue, you will start to form what's called a Q wave. And the Q wave is something that we'll talk more about in a few minutes or a little bit later in this talk today. But so that top of page 10 is a good kind of an overview of what we're getting into. For a few, and then also as you look at page 10, there's examples, and it shows examples to the left toward the bottom of the page of ST segment straightening, sagging, and depression. Those are forms of ischemia, and again, ischemia is lack of oxygen to the heart. ST segment depression is the main one that you want to think about. That's the one that we'll emphasize, and that's the most common one. If you look to the right of that on page 10, there's something called non-specific signs of ischemia, where it means they could be ischemia, but it could be something else too. And we're usually talking about a T-wave problem, like a flat T-wave or inverted T-wave, or what's called a biphasic T-wave, where the T-wave goes up and then down, or sometimes even down and then up, like that. And so those are some examples. On page 11, there's EKG examples that are pretty good, but we have some better ones actually in the course pack that we'll be looking at. So to clarify, ischemia is something where the heart lacks oxygen, and you can say ischemia, some people say ischemia, and this is where you focus on the ST segment, and that's a specific sign of ischemia. So ST segment depression especially is a sign of ischemia. The T wave, if that has flattening or inversion or biphasic, that's non-specific. It could be ischemia, it could be something else. In general, ST segment depression is the standard for diagnosis of ischemia, whereas in general, ST segment elevation is the standard for diagnosis of injury, and then eventually even infarct later. We will, again, if you're looking at the PowerPoint, that's pretty much shown on there. If you look if we drop back to page 9 in the text, this kind of goes with this too, where there's a picture of T waves in the leads V1 through V6. We studied V1 through V6 last time. The T wave should be upright almost everywhere in the EKG, but in V1 through V6, you can see that it should be upright in V1 through V2 through V6, but inverted. It's normal for it to be inverted in V1. So the T wave can normally be inverted in V1. And again, look at page 9 for that material. Okay, going on to the next slide. Changes is a word that didn't make sense to me right at first when I started clinically, but changes just means something different than normal. So normally, we have in most leads an upright T wave, but you could say that if somebody has T wave inversion, they have T wave changes, just something different than normal. So just kind of a different definition of that word. In the course pack, if you go to that on pages 8 and 9, page 8 at the top is like a classic example of ST segment depression at the top, and that's somebody that definitely has ischemia, lack of oxygen to their heart, again due to blockage called atherosclerosis, usually as a result of lifestyle. If you look at the bottom of page 8, middle and bottom, this is a patient that I worked with that came in for a test, and he was reporting that he had some symptoms in his chest, and we did tests on him and had him on a treadmill. And if you go from the resting EKG to the exercise EKG, you can see in V2 and V3, he has a lot of, this is a very pronounced example of ST segment depression. So he definitely has blockage in his heart, coronary artery disease, and it was interesting that he, just as an aside to this, that he cleared up his lifestyle over about a year. He stopped smoking, he started exercising, he started eating well, he lost a lot of weight, and he actually, this patient reversed a lot of that. He had a test that was fairly normal about a year later, or didn't show anything of that degree, so that was kind of a real good case for him, or a good job done on his part. But again, on page 8, that's a lot of ST segment depression, and that's definitely a very specific evidence of ischemia. On page 9 in the course pack, there's an example. It's a 12 lead, and there's an example of kind of all over the 12 lead, a lot of ST segment elevation. And ST segment elevation is a form of ischemia that can be what's called transmural, all the way through the muscle. That's one reason for ST segment elevation. There are other reasons also. This is one, and I'll go over that list in a second, but this is one where if it's found all over the EKG, a lot of ST segment elevation, it's often caused by pericarditis, which is an infection in the heart, and that can lead to ST segment elevation. And the person that has the EKG on page 9 actually has pericarditis. So you should see ST segment elevation on there. While we're talking about ST segment elevation, if you look to page 12 in the small book, there are several reasons for ST segment elevation. We've talked about a few of these already. One is injury. Injuries where the heart is going toward infarction, but it hasn't quite gotten there yet, and there's an injury pattern, or the heart is injured. That's ST segment elevation. And then there's what's called Prinzmetal angina, is where somebody has a coronary artery spasm, and that can lead to transmural ischemia, which is also a type of ST segment elevation. And then aneurysm, ventricular aneurysm, leads to ST segment elevation. Pericarditis that I mentioned, and inflammation or infection in the heart leads to ST segment elevation. Some people have ST segment elevation as a normal thing called early repolarization, which is a normal variant, and that can happen just as a normal thing. So if you look on page 12 in the text, those are the author titles it as injury, but it really should be titled as a list of reasons for ST segment elevation. Okay, again, to summarize the topic of ischemia and injury, you have as a reference this little part of the PowerPoint that I'm talking about, so you can use that information. In the course pack, the big book, you want to make sure you see those examples clearly on pages 8 and 9 as examples. And then in the small book, the text, we looked at pages 9, 10, 11, and 12, and that can be a good resource for that too. The topic that goes with this material is the next slide, where, and we've already mentioned this a little bit, where you can have myocardial infarction. And myocardial infarction can be referred to as infarct or infarction or even MI for myocardial infarction. And this is where, if you take a quick look back on page 10 in the small book at the top, the author shows that there's kind of dotted lines in there where the heart muscle has been damaged. And if it's been damaged, then you have myocardial infarction. That means that those cells in the myocardium will never return to normal. They've been necrosed or damaged. And hopefully, if it's a small area, then the patient usually can have a fairly normal lifestyle, maybe with some limitations. If it's a larger area, then it's more problematical. But so we're interested from an EKG standpoint in the diagnosis of myocardial infarction or infarction. And before we really look at anything, we want to think in terms of what we're looking for is the development of a Q wave. And the Q wave, and again on page 10 in the text, you can see in the upper right on page 10, as the patient goes from injury to infarction, the thing that develops, if you look at that closely, is a Q wave. And you can also see the arrow moving in that direction. Once somebody goes into infarction, again, that's not reversible. That you can never go back at that point. That area is going to be damaged for good. The strategy clinically is to reduce the area of infarction by trying to get blood flow into the heart as quickly as possible and trying to save the areas surrounding the infarct area. So anyway, from an EKG standpoint, we want to be looking at Q waves. And before I even get into what's on the PowerPoint slide, which actually starts at the top of page 13 in the text, I want to take a look at page 10 in the course pack. In page 10, and then we'll get into the details in a second. Page 10 is the kind of an overview EKG. It's a 12 lead. And we looked at 12 leads before. The leads are labeled 1, 2, 3, AVR, AVL, AVF, and V1 through V6. And in this 12 lead, the thing that really stands out to me, or to anybody that's reading EKGs, and to you as learning about reading EKGs, is that in leads 2, 3, and AVF, there is a large downward deflection right before the R wave. Remember, the R wave is the large upward deflection in the EKG. And that significant or large downward deflection is definitely abnormal, and that's a Q wave. That's part of that QRS complex. So clearly, in looking at this, page 10, we would say that this person has had a myocardial infarction or an infarct. And later we'll be able to locate where it is and get the age of it and everything, but it's in 2, 3, and AVF, you see that large Q wave. So now if we go back to the kind of the written material on this slide, and then starting on page 13 in the small book, the text, you can see that, and this is at the top of 13, but also pretty much summarized in this PowerPoint, for transmural infarctions, this is an infarct where the infarct goes all the way through the muscle, and this is really the common infarct, transmural. This is the main one that you want to be thinking about. They're often called Q-wave infarctions. You scan the 12 lead for Q waves. You can look in all leads. You look for them in all leads. Now they will occur only in some of the leads, but you want to look everywhere except AVR. AVR is the only lead of the 12 that we do not use for infarct. And so on this EKG, back to page 10 then, as you scan through, you would see that those Q waves are in leads 2, 3, and AVF. And so that would be a type of infarct. And again, we'll get back to location and age of infarct in a little bit. The Q wave has to be pretty big. And you can think in terms of some of the stuff that I have in the PowerPoint. It's also in the book. I think it's a little bit clearer in the PowerPoint exactly what you want to know. But we'll be talking about some Q waves later that are small and normal. But an infarct Q wave is pretty significant in size. Should be about greater than 0.03 seconds in duration. That means that it's wider than a small box. I wouldn't get real into the details of that, but it's just kind of wide is what you want to be thinking. Should be 1/3 to 1/4 of the height of the R wave or more in the same lead. And that, again, without the details, kind of a deep or big Q wave. is what you're thinking about. And it's usually seen in more than one lead, like page 10 where it's in 2, 3, and AVF. So the point of that bullet on the PowerPoint is that it's a big Q wave, and we'll be looking at some of the smaller ones later. Another thing you should look for is a poor R wave progression in the horizontal plane, leads V1 through V6. And this is where, and we'll look at a lot of examples, but if the R wave should be increasing in size through those leads. We talked about that earlier in the course when we talked about in the area of rotation. And so if it's not increasing in size, then that could be a type of infarct called an anteroseptal wall MI. And I know that's fairly new concept right now, but we'll look at an example of that as well as everything else. So far in this slide, you should be thinking about looking for a big Q wave, and you should also be looking for that poor R wave progression in V1 through V6. And again, we'll reinforce those with examples. The other thing you should look for for an infarct is a tall R wave, an R wave larger than an S wave in V1 and V2. Mainly focus on V1. And this is where you have, normally in V1, as we learned earlier in the course, the R wave should be smaller than the S wave. If the R wave is larger, then that usually is a flag towards something, and one of the things that you could diagnose in a lot of cases is a posterior wall MI. So that's another thing to look for too. If all of these words seem a little new, and they should, we'll be seeing a lot of examples and going through all this stuff, but it's a good starting point. But again, if the main thing you want to think about is page 10 at first, looking at those classic Q waves in 2, 3, and AVF, and that's an infarct without a doubt. And we'll be looking at that example and others in a little bit. Before we look at examples, I want to talk about Q waves that are normal, because you might have an EKG, and you might look at it, and you've had this course and stuff, and you could say, well, you know, I see some little Q waves on my EKG. Have I had an infarct? And generally, if you have small Q waves, the answer is no. And if you look even on page 10, since we're looking at that right now, if you look at, say, V6, to the far right, lower part of the page, there's just a little Q wave in there. And these are normal, these little Q waves. It's due to depolarization of the interventricular septum. That's the septum that separates the right ventricle and the left ventricle. And they're small, they're normal, they're not due to infarct, and they're very common. So again, when you're looking for infarct, look for large Q waves, not these small, what are called septal Q waves. That's a part of the differential diagnosis. Moving forward, we want to think in terms of, and again, we'll come back to a lot of examples, but the age of the infarct. So now we've said so far that we have Q waves, generally, with a couple of exceptions. You know, we said there was the poor anterior R wave progression and the tall R wave in V1 as being infarct examples too. But the main thing, again, is to look for Q waves. And when we look for Q waves, we want to think in terms of not only is there an infarct, but when did it happen? And when did it happen, the age of it is important in how you are treating the patient, what you want to do as far as any kind of additional therapy at the time. And so we have, you're looking at should be looking at the PowerPoint slide now with C, uppercase C, infarct age. And on the next slide, we'll look at the written criteria, and then we'll look at several examples going through this. And I think probably the best way to go through this is to actually, as I talk through the next slide, to be looking at the course pack and looking at each example along the way. And this, before we do that, the concept of infarct age, or when did it happen, applies to all infarct locations. And we'll be talking about a little bit about infarct locations in a few minutes. So go to the next slide, and this is infarct age. It's almost like a little chart. And if you're looking at this infarct age, you should also be looking at the course pack on page 11. And we want to follow an infarct. This is a real case that I was involved with in the hospital, so I'll add a little bit of a story to it also. And this person's infarct was in 2, 3, and AVF. Same infarct that we saw on page 10, same as that infarct 2-3 and AVF. That we'll see other areas in a few minutes. But this infarct then, and we'll learn in a few minutes that 2-3 and AVF is an inferior wall infarct. That's something I'll talk about in a few minutes. But if you look on page 11, in leads 2-3 and AVF, bottom left of that, and there's arrows in there, you'll see on the EKG that there's this is an acute MI. There's a Q wave with ST segment elevation. And where the lowest arrow is, the one that's pointing up, you're just barely forming a Q wave. It's just starting. In fact, it's just coming out of the injury stage that we talked about a few minutes ago. And you can see where the arrow that's pointing down is. This is in lead 3. There's a lot of ST segment elevation. So that just the beginning formation of a Q wave with ST segment elevation, which is usually pretty tall, is an infarct that's called acute. And this is generally just hours old. This person should be getting care as quickly as they can, getting into a hospital, and then getting trying to open up the vessels as fast as they can to save heart muscle tissue. They've lost some, but you want to save as much as you can. So that, again, just to say on page 11, that just a small Q wave with ST segment elevation is an acute MI. If you flip to page 12, and again, we're still looking at leads 2-3 and AVF, that type of infarct, just to stay with one for a while. This is called acute progressing. That's the next stage. And this is where you have Q waves. And again, if you look at the arrows on there, that can be helpful. The Q wave has gotten much bigger. If we were in a classroom right now, I would be asking, what's happened to that Q wave, and it's really grown a lot larger, but it's still there, and that's where that one of those arrows is. And then you still have ST segment elevation, and that ST segment elevation has actually come down a little bit, but it's still elevated, and the T wave is starting to invert. So you should be able to follow those 3 arrows and see the Q wave, ST segment elevation, and T wave inverting. And this means this is a person that where it would be days old, acute progressing. This person, I mentioned on the acute one before, they had come into the hospital, and I had seen them in the emergency room. Now that they went to the acute progressing, they had been in the hospital a couple of days, and I went up to the patient's room to see them for what we call a phase 1 cardiac rehab. That's a whole other topic. And we looked at the EKG, and we saw this pattern of acute progressing. So it's a few days old at this point. And then if you look on page 13 in the course pack, you can see that there's still a Q wave in that area, that same area. The Q wave is pretty much gone in lead 2, but in lead 3 it's still there. And in lead AVF it's still there, especially in lead 3. The Q wave is pretty big. You can see that the ST segment has come down to baseline and the T wave is inverted. This is what we call a recent infarct. And this is, so you have a Q wave with the T wave inversion but no ST segment elevation. Just reading that part off the chart in the PowerPoint. And this is something where this patient, I was there, so I know it was about a month later. It's usually like weeks old, say like maybe 2, 3, 4, 5, 6 weeks old in that area. So this was somebody that had come back to the hospital for what we call phase 2 cardiac rehab. Again, a topic for a different course, but their infarct is a few weeks old, and that's called recent infarct. And sometimes, there's a little note on page 13, that sometimes this MI never changes. It just keeps that pattern for life. And it doesn't mean anything necessarily good or bad, it just never comes out of that pattern. But and then it could be what's called an old or previous infarct, but actually that's the recent infarct pattern. If you look to page 14, most of the time the infarct will start to continue to evolve where everything is normal. And again, we're looking at pages 2, 3, and AVF on page 14. And the ST segment's normal, the T wave is normal. The only thing left on this, and it's actually pretty small at this point, is the Q wave. The Q wave is usually the part of the EKG with an infarct that stays there the longest. And again, it's gotten quite small. but this is what's referred to as a previous or old infarct, maybe months to years old. And most of the time, this pattern with the Q wave only is what the person has for the rest of their life. You'll always see the Q waves there for this type of person most of the time. In some cases, the Q waves do disappear, but usually that's kind of rare. Usually the Q waves will be there throughout. So this, again, the summary of this part then, we're still mainly looking for Q waves. And we're thinking in terms of the age of the infarct. When you take the exam, you'll have EKGs to look at, and you want to determine the age of the infarct based on this chart and these patterns. Okay, the next area is to go to the infarct location. And some of you might be thinking, you know, he's only been talking about Q waves so far. What about those other things that you had talked about, like the poor R wave progression and the tall R wave in V1? And that's where, when we talk about the location, we'll get into that material. So if you look at this slide now, which is the D in the outline, infarct location, and this goes with page 15 in the course pack as a beginning point. And you can see we want to look at where the infarct is in the heart. And most of these infarcts are on the left ventricle of the heart. And so we'll be looking at EKG examples in the course pack, along with a chart, which is on the next slide. And then we'll have you get some practice with this with some examples that are coming up. So page 15 to begin with. And again, we are mainly looking for Q waves. So if you go to the next slide, this is, again, a little chart on the location of the infarct. In a multiple choice type of question on exam 2, this could be something like, Q waves are seen in leads 2, 3, and AVF, so where is the infarct? And I could have a list of these things, and you would pick out inferior wall infarct like that. But more importantly on the exam is that you would be looking at EKGs and finding this material and then determining the location of the infarct. So let's begin with the top one, inferior wall infarct. This is one that we've looked at throughout so far as the example. In fact, page 15 is similar to what we've seen already. You can see where the arrows are, 2, 3, and AVF, leads 2, 3, and AVF. And so this is, if the Q waves are in those leads, that's an inferior wall infarct. So that infarct is on the kind of the bottom section of the heart, inferior wall infarct. We've seen quite a few examples of that. That's where you really want to make sure you have that down before we go on. So really look at that one and make sure you understand seeing the Q waves in 2, 3, and AVF would indicate an inferior wall infarct. You just have to memorize the leads that go with the areas. If you look to page 16, again, we have a 12 lead. And if you look at leads V1 through V6, there are Q waves that are in all of those leads, V1 through V6. In fact, there's basically no R wave in V1, and then the R wave starts to get a little bigger, but there's the first deflection is a downward deflection, and that's an anterior wall infarct. That's generally a pretty large infarct, generally not a good infarct to have clinically. Usually it involves a lot of the heart, and damages a great portion, which can usually affect function later on. So that's an anterior wall infarct on page 16. Make sure you see where that is, and again, we'll have more practice on that later. Page 17 is what's called an anterior septal wall infarct. It's really a type of anterior wall infarct that's a little bit smaller. So it's an anterior wall infarct that is a smaller part of the anterior wall, so it's called anterior septal wall infarct. And usually here on page 17, you see your Q waves in V1 and V2. V1 definitely has the Q wave. V2, you could even say, well, there's probably a little bit of an R wave, but very little, enough to where you would just generally call that a Q wave. This anterior septal wall infarct is that type of thing where you have poor progressing of the R wave. The R wave is not getting bigger from V1 through V6 as we studied earlier. It's just not, on this example, it doesn't get bigger until real late, and even then it's not very large. So that's that anterior septal wall infarct, usually V1 and V2. When we go to the exam, you'll have EKG examples and you want to determine, the area of the infarct or the location, and that would be anteroseptal. If you go to page 18 in the course pack, this is it's not a full 12 lead. It's V1 through V6. And you can see in V1 and V2, the R wave is starting to get bigger from V1 to V2. But then when you go to V3 and V4, where the arrows are, we've lost the R wave. And this is kind of an unusual infarct, actually, but it's infarcted the what's called the anteroapical or direct anterior wall infarct. Usually has the Q waves in V2 not V2, V3 and V4. V3 and V4. And so an anteroapical or direct anterior wall infarct has Q waves in V3 and V4. And again, that's actually a subset of an anterior wall infarct. Okay, the next one is on page 19, and you can see that this is what's called an anterolateral wall MI, or infarct. And this is where you have Q waves found in V5 and V6, even sometimes V4 is shown there. Sometimes it spills over a little bit to another area of the heart, but generally V5 and V6. And then also leads 1 and AVL. So as you look at page 19, you should see those Q waves in 1 AVL, and then actually on that page V4, V5, and V6. It might only be V5 and V6 in a lot of cases, but that's called an anterolateral wall infarct. So that's on the kind of more to the front left part of the heart. That's where the infarct is. And then the next location, and again, take your time, with this material and think about, where these Q waves are. Let's use page 19 also for this one. If you have, and we'll see an example of this one later, but if you have Q waves only in leads 1 and AVL, only those areas, but not in V4, V5, and V6, so just say they aren't there, but 1 and AVL, that's called a high lateral wall infarct. And that's where the infarct is, again, to the left side, but kind of high up, more toward the more superior, and generally, often, kind of a smaller type of infarct. So again, we're looking for Q waves, and that would be an example where you see them in 1 and AVL. We have a good practice example of that coming up later. And then, so that's, again, the Q wave idea. The one that's a little bit different than having Q waves is what's called the posterior wall infarct. And this is often called a true posterior wall MI. You can leave out the word true, or you can leave it in. Either way is fine. And this is where you look at having a tall R wave in V1 and V2, and an R wave bigger than the S wave in V1. And that's unusual because the R wave should be smaller than the S wave. And this is where somebody has a posterior wall infarct, which is on the back part of the heart. On the slide, I have the words mirror image. And this means that if you, and you can try this, if you take that EKG and flip it over and then put it, look at it through a mirror, put it up to a mirror and look at the mirror, it'll look like Q waves with ST segment elevation. So it's kind of like a mirror image because it's on the back of the heart. But again, this one is the one that's quite different from the other ones, and this is where you have basically a tall R wave in V1 and V2. R wave bigger than the S wave, and that's a posterior wall infarct. If you continue on page 21 in the course pack, this page is not testable, but it's just in there for kind of future learning or a challenge. This person actually has Q waves in 1, 2, 3, AVL, AVF, in V4, V5, V6, and then a tall R wave in V1. So like all over the place. And this infarct is actually, and you can read this in your course pack, an infero-posterolateral wall MI. It's a big area. It probably was multiple infarcts in those areas. The lateral, the inferior, the posterior, part of the anterior, probably had 2 to 3 infarcts, which some patients actually have. And page 21 is beyond the scope of the course and just for fun, but it's a pretty extensive infarct that kind of puts together a lot of the material that we've been talking about. Okay, going back to the PowerPoint then, before we do examples, there's one exception where it's not a transmural infarct. And the best resource for this is looking at pages 18 and 19 in the small text. And these are non-transmural infarcts, or non-Q-wave infarcts. What that means is the person has infarcted, but the infarct does not go all the way through the muscle. It just goes kind of in the underneath part, or subendocardial part of the muscle. The inner layer would be probably a good way to say it. And these are called subendocardial or intramural infarcts. And if you look on pages 18 and 19 in the small text, that's a pretty good summary of what's going on. With this then, you can have ST segment depression. And this can represent a subendocardial infarct. And you might be saying right now, well, that could be ischemia too. And that's good if you're saying that, because we studied that, and that's true. But what you do is, if you have a patient with ST segment depression, you can take a blood test. And if they have elevated cardiac enzymes, this is on the PowerPoint slide, in the blood test, that elevation of enzymes means that enzymes have leaked out of a damaged heart. And therefore you have a leaky or infarcted myocardium. And so you've lost some of the heart muscle, and the enzymes leak out. And therefore the ST segment depression would mean subendocardial infarct. If you have ST segment depression in normal cardiac enzymes, and this is really the common situation, is that you would have ST segment depression without elevated enzymes, this is ischemia then. And so if you're are doing maybe a test on somebody, a treadmill test or GXT, you could have them walking on the treadmill, they'll get ST segment depression, they'll have ischemia, you'll have them sit down and it goes away, and chances are that's ischemia, and that's the more common thing. But if you do have that depression with an enzyme leak, then you have what's called a subendocardial infarct. So that's just another type of infarct. And then another one is where the infarct doesn't go all the way through the muscle, but it just goes kind of inside the inner area of the muscle. And this is where you have deep T-wave inversion, and this is called an intramural infarct. Intramural. And if you look on page 19, you can see that deep T-wave inversion, especially in, say, V3, V4, V5, and that's pretty representative of an intramural infarct. Usually that has an enzyme leak also with it. So this is not real important compared to the rest of what I was talking about, but it is a piece in the puzzle in an overall diagnosis of infarcts. But again, the more important area all around is seeing the Q waves in the infarct that way. But this is just kind of some material that goes with it. So now we get to the fun part, where we want to look at practicing some of these, especially transmural MI practice. On the PowerPoint material for the next 5 slides, we have an EKG, and then it's followed by the answer. And if you could, to maybe challenge yourself, you could look at the EKG and then see the answer a little bit later after you've made your diagnosis on the slide. And again, kind of compare to examples that you've seen and stuff that we've talked about. And this is where you can really test yourself to find out if you're ready for moving on to the exam. The first one then, if you click to the next slide, is doesn't show a full 12 lead, but it has leads 1, 2, and 3 in AVR, AVL, and AVF, and you want to look for where you're seeing the Q wave. So take a look at that. You can pause here if you want, and the Q wave can be seen then, and hopefully you've paused and thought about it too, in 2, 3, and AVF. And so if we click to the answer, Q waves in 2, 3, and AVF would indicate an inferior wall infarct. And again, that's that one that we've seen quite a bit of. And if you can do that, you know, that's a good start. That's good progress toward this. Another example, the next example, is take a minute to look at that. Again, scan for Q waves and look for anything, you know, that goes along with that too. And you can see that in leads 1 in AVL, you have definite Q waves. and then leads V2 through V6, you have definite Q waves. And so this would be an infarct that is pretty big, and it's involving, and again, you want to take notes on this and think about it and make a diagnosis, but hopefully you put that this is involving the high lateral wall and the anterior wall. So if you go ahead to that next slide, you'll see Q waves in 1 and AVL and V2 through V6, anterior and high lateral wall infarct, or MI. And that's a pretty big infarct, or that may have been a couple of different infarcts at different times. If you go forward then to the next slide, and again, you want to look through this, look for Q waves. One thing to reinforce this, there is a Q wave in AVR, but again, AVR is not, that's the one lead that we do not use for an infarct. So don't worry about that Q wave. Okay, you should be seeing Q waves in leads V1 and V2. And that's where you have, again, that idea of the terminology that I mentioned called poor anterior R wave progression. The R waves are not getting bigger through those leads. They're not there in V1 and V2. And so this is an anterior, if you click ahead then, anterior septal wall MI Q waves in V1 and V2. If you are seeing these, you're doing a great job at making the diagnosis of infarct on the EKG. If we move forward to the next one, I mentioned that the course pack didn't really have a good example of this, so I mentioned that there would be a practice one. And so again, you want to scan through and look for Q waves. You should see Q waves nowhere, should not see them anywhere other than leads 1 and AVL. In leads 1 and AVL, that is that infarct that hopefully you're getting the right answer here with a high, if you click ahead, high lateral wall MI. So that's a great example of that, high lateral wall. The next one, you scan through for Q waves, and you see that, again, take your time with this, there's pretty low voltage in leads 1, 2, 3, AVR, AVL, and AVF. And I think if we made that larger, leads 1 and AVL might actually not look so much like a Q wave, but don't worry so much in that area. The main thing you want to see here is that R wave in V1 and V2 that's bigger than the S wave. In fact, there's no S wave, so a very large R wave in V1 and V2. And this is that infarct that is a posterior wall infarct, often called true posterior wall infarct. And if you flip this EKG over and put it in a mirror, it would look like a huge Q wave in V1 and V2, and it would look like T wave inversion. And so that would be your posterior wall infarct. So again, if you've, and the answer's on the next slide, tall R waves in V1 and V2, posterior wall infarct. If you've gone through those examples, that's a great start on being able to read EKGs and determine the diagnosis for your patient. So good job with that. That's the whole area of ischemia, injury, and infarct. And that, again, is part of Module 2, the first part of Module 2 on Exam 1. And now we'll go on to Part 2 of Module 2 for Exam 2.